Honorable chairpersons, friends, colleagues, ladies and gentlemen, a very good morning to all of you. Dr. Sanjay has given a very elaborate talk on muscles. So let us see how these muscles, they create the para-anal and para-rectal spaces and what are the pathways of spread. So we know about all the potential spaces which are there, and numerous spaces are there. So I will try to share with you each and every space and how the pathways of spread they take place. Now coming to the ischiorectal fossa, just remember the rule of 5. It is very simple: 5 centimeter long, 5 centimeter wide, and 5 centimeter in depth. Very simple. Posterior-laterally, there is present Alcock's canal, and Alcock's canal, from there comes the pudendal nerve and pudendal vessels. So what we get over here is fat and the branches of the pudendal artery, pudendal vein, and the inferior rectal branches of the pudendal nerve. Clinical significance, Dr. Sanjay has told you about the CLM. Now one part of CLM, it goes outside to form Milligan septum. In case an abscess is formed over here in the ischiorectal fossa, until and unless it penetrates the Milligan septum, there will not be any clinical signs of inflammation. Very, very important to know. Patient may come to you with pain, you don't get MRI done, you put it on analgesics, but suddenly you realize there is no relief. Subject the patient for MRI, you may find an abscess over there. Perianal space, now this is the Milligan septum, ischiorectal fossa. The lower one is the perianal space. Two important structures which are lying over there. One is the external hemorrhoids which are there, and secondly, it is the commonest site of the perianal abscess. Because the anal glands which are present, they are normally 6 to 8 in number. We will come to that side again. But they have got around 12 to 14 ramifications, and these ramifications mostly they go downwards. That is the reason most of the cases we get perianal abscess over here along with intersphincteric fistula. Intersphincteric space, as the name indicates, it is between the internal and the external anal sphincter. Now, whenever you read any publication, 1956, 1958 by Eisenhammer and 1961 by Park, they have all said that this is a space from where an abscess or a fistula starts. That is the intersphincteric space, and that is the importance of that. Submucosal. We know about submucosal space, that this is continuation of the rectum and it ends at dentate line. Now, two important structures which are present. One is submucosal glands, which are present in 80% of the patients, in 80%. And secondly, we have got internal hemorrhoidal plexus, from where superior hemorrhoidal plexus, from where we get the internal hemorrhoids. So these are two important structures which are lying over there. Superficial postanal space, Dr. Sanjay just told you about the insertion of the superficial part of the external sphincter. So that is inserted into the coccyx. So what we get, this is a coccyx. So what we get superior to that, means anteriorly, there is present the superficial deep anal space, and posterior to that, where the anococcygeal ligament is there, that lies the deep postanal space. So what is the clinical significance? Why we want to know about it? This deep postanal space continues on both sides with the ischiorectal fossae. That is the reason we get horseshoe fistula. And until and unless you open this space, the patient is never going to be cured. So very important for you to understand, and exactly where it lies. From the anal verge to the coccyx, midway between that. So this is a slide which just to show, this is original Henle's. Henle's is a procedure which he told that the deep postanal space should be opened And in case you don't make a posterior fistulotomy, give a nick over here that is called modified Henle's. And this is how both the abscesses can be drained from here. Supralevator, as the name indicates, it's above the levators. Now we know pubococcygeus, it has got three parts: puborectalis, pubovaginalis, and pubourethralis. So this is the puborectalis, this is a peritoneum, this is a supralevator space which we get over there. What the importance, how the abscesses are formed, we will come to that later. Now see this slide. We always talk about infralevator space, but the most important thing is how it is formed. In between the subcutaneous and the superficial part lies the Milligan septum, which is a part of CLM. But in between the deep and the superficial part lies another septum, which is called septum of ischiorectal fossa. Now this divides the ischiorectal fossa further into two parts. The lower one is the clinical ischiorectal space and the upper one is the infralevator space. This is the space where we get infralevator abscesses. As the name indicates, this rectorectal space, it lies behind the rectum but in front of the sacrum. Now any abscess can extend over there. Many times you will find reports with the radiologist reporting there is extension of an abscess into the rectorectal space. But this is the common space for pre-sacral tumors. Now this is a space which very few people talk, but this is something which was described, I think, about 60 years ago. Deep intersphinctic space. Now this is the anal verge, this is the anorectal ring. This space lies exactly midway between these two structures, that is anal verge and the anorectal ring. Now what is the clinical importance? Whenever you are excising the internal opening, please do open this space. In case you don't open this space, chances of recurrence are very high. That is the reason Park said that you excise the internal opening, taking half a centimeter of the margins all around. So everything is scientific, not just to mention something. So that is the importance of the deep intersphinctic space. Now deep anterior anal space. Now this is very important. We know this is a urogenital diaphragm, imaginary line between the two ischial tuberosities. Above is the urogenital triangle. So what is the importance? I will tell you during the pathways of spread. It's a long talk actually. Ma'am, just give me 2-3 minutes extra. Huh? Now this is anatomy. Dr. Sanjay told you about the embryology. There was a very good paper from Singapore by Francis Sion. Now what he said, 80% of the glands, they are present into the submucosal space. And only 20% they cross either the internal sphincter or the intersphinctic space, or maybe 1% they cross even the external anal sphincter. So why we want to know about all these glands? What is the importance? Because all these glands, they secrete mucin. And whenever mucin is secreted, and this forms a channel between the anal canal and the muscles. So whenever there is a blockage of this gland, it will simply lead to infection, stasis, then infection, followed by abscess, and finally a chronic phase that is called fistula. Pathway of spread. Now, the disease can spread either vertically, or there may be horizontal spread, or there may be posterior spread. So whenever there is a posterior spread, what we get? A horseshoe fistula, whether it's intersphinctic or rectal, or it is a suprasphinctic. So that is the importance of the spread. Now from intersphinctic, how it spreads, this is the intersphinctic space. Now we know about ligament of Treats, it goes medially, and these are all potential planes from where the this infection can spread medially.
Don't get surprised when a radiologist reports there are two internal openings. One is a dentate line and second is slightly in the distal part of the rectum. So from where that opening is coming, because one part of the extension has opened over there. So that is the reason you get two internal openings with one or single internal external opening. Laterally, it can form outside ischiorectal and downwards again perianal. So this is how the intersphincteric abscess is formed. Upward extension can lead to supralevator, downward can lead to perianal. Now lateral extension, as I already told you, it can lead to ischiorectal abscess. Anterior spread. Now this is to show, this is the perineal membrane. We know about this. Now two important pouches are there, superficial and deep perineal pouch. The inferior boundary of the superficial perineal pouch is formed by the Colles fascia. Colles fascia continues as dartus fascia and dartus continues at the scarpus fascia. So let us try to understand. Posteriorly it is gluteus maximus. Now this is a patient you can make out very clearly. This is a intersphincteric abscess. This is the anterior abscess. And once we had gone for surgery, this was a picture taken after maybe 7 to 10 days. See the perineal body. Dr. Sanjay told you about how the perineal body is there. Internal end sphincter, superficial part of the external sphincter, bulbous spongiosum, ischiocavernosus, all the muscles you can see over here. So that is how the perineal body looks. Anterior spread. Many times we get in males the abscesses which are present in the scrotum or the penoscrotal junction. The external opening is there. So from where it has come, it is the anterior extension which is from the Colles to the dartus. Now this is another important pathway. See, unlike any other structure, the ischiorectal abscess does not have the fascia like skin, superficial fascia and deep fascia. No. In between superficial and deep fascia lies fat, and this is called fascia lunata. So the space which is present in between fascia lunata and the levators, that is called infralevator. So any abscess from here can spread and go over there to form a suprategmental abscess, because that is a suprategmental space. So that is how an inferior levator abscess is formed. Supralevator, as I told you, it can go right from the internal intersphincteric space above. Then this is the ischiorectal, but it can pierce the fascia of the levator ani and form a supralevator. Then any pelvic infection can extend downwards to form an abscess over there. So these are the commonest pathways to form a supralevator abscess. Posteriorly, already I told you, it can be intersphincteric, ischiorectal, or it may be supralevator. Now, see this slide. So we have already discussed about the fascias. Over here, this is dartus fascia forming an abscess. Penoscrotal, again dartus fascia forming, but dartus fascia continues as a scarpus fascia. That is the reason we get an abscess formation in the lower part of abdomen, and it can go up. And medially, it can penetrate the deep fascia of thigh, which is called fascia lata. That is one of the reasons we can get a swelling or an abscess in the medial aspect of thigh. So all the answers, they lie over here in the anatomy. So what is the fate? It can burst an abscess, it can burst and form a fistula, or it can remain undrained and lead to sepsis. Thank you very much. Yes, ma'am. Any questions?
It's always very confusing and difficult to understand the spaces and spread of the abscess. But you have made it very simple and we could understand easily now.
Thank you, sir. Thank you. So I have got a problem with myself. Complicated चीजें मुझे समझ नहीं लगती. So what I cannot understand, how can make anybody else understand? So I tried to present in a very simplified way. Thank you, sir.